Hello everybody, my name is Cormac Cowens. As Claire said, I'm from Dublin, and it's a real pleasure and a treat for me to be here with you all. It's a privilege, and I would like to thank Nick for talking me into it. I hope it wasn't too hard, and I have big shoes to fill from the previous moderator, who's a friend, Daniel Morgenstern, working in Toronto. So I just wanted to explain a little bit about how the day will go. Obviously, we have a lot of people in the room. We have over 220 families online. And so this is going to be a little bit of an experiment, if I'm allowed to say that, but we want to try to have as much engagement during the day. I think it's a really important day, not just for the families, but for us as well, that we can hopefully inform, educate, answer questions, and help everybody be in a better place maybe by the end of the day in terms of information and knowledge. So we're starting off with an introduction to neuroblastoma, and then we have a session on relapsed and refractory disease, and then how we measure response to disease, which is a really hot topic and very important, with the focus on not using scans. So how can we do this in the future in an easier, more child-friendly way? We have a question and answer session at the end of each session. So we'd ask you to keep your questions to the end. We're going to try to moderate the online questions as well, so that everybody online feels that they can answer their questions, and hopefully we'll get to as many of them as we can. And the other thing I wanted to do was just to explain a little bit of the lingo. So pediatric oncology is full of acronyms, which can be very complicated. But I think for today, two very important acronyms are COG and CUPEN. So COG is the Children's Oncology Group. It's the group of hospitals and individuals in mostly North America who look after children with pediatric cancer and are developing trials and research. And the relative equivalent for neuroblastoma in Europe is CUPEN. And so most of the doctors and researchers you'll hear today either work in COG or CUPEN. I think hopefully you can see that we work very closely together. We know each other really well, which is hopefully reassuring to the wider community that we talk to each other and we're trying to make things better together, not in isolation and not in silos. So that's the run of the day, and hopefully you'll feel an opportunity to interact with us. So please don't be shy about asking questions. If you feel able to introduce yourself, that would be great, but sometimes we forget and sometimes we might be shy. So most importantly, we would like to hear your questions. And so I'm the moderator for the first session as well, which is an introduction to what neuroblastoma is, and I think very relevantly, after we've finished the prescribed or planned known treatment, what other treatments might be available and how would we consider using them. So to start, I'm very, very pleased to mention somebody who came slightly further than me to be here with you, and that's Dr. Bagatel, who is the chair of the Neuroblastoma Committee in COG, the Children's Oncology Group, and a very, very dedicated clinician to the cause of making children with neuroblastomas' lives better. So thank you, Ro.
Thanks, Cormac. Thanks to everyone for coming this morning, and thanks to the SKC team for inviting me to join you. It's my pleasure to be here, and I have to say, I flew a couple of days ago, so I'm awake, but also I'm having a great time in your country. It's fantastic. Okay, so I was asked to give a little introduction to the day and cover really what is neuroblastoma, and I think you'll find out from the next few minutes, it's so many things, and if your experience with your child with neuroblastoma is really different from the experience of the person or the family sitting next to you, it's because the disease is so many things, and your experience is going to be uniquely your own. The next few slides will go through a number of different aspects of neuroblastoma, sort of a tasting menu for what many of my colleagues will talk about over the next 2 days. So key messages: neuroblastoma is a tumor of the developing peripheral nervous system. See, I spelled it with a U, tumor. I did it right. And I'll talk a little bit about what that means. The biology of neuroblastoma is quite complex, and we're trying to learn more and more about it by the month, by the year. Treatment depends on risk classification or the risk of disease recurrence. And we have to stay humble all the time as we think about neuroblastoma, as we study neuroblastoma, and as we care for you and your children, because we have so much more to learn about this disease. So first, I know all of you know this, but your friends and your family and your third cousin twice removed next door neighbor might hear the word neuroblastoma and think that it's a brain tumor and say, "I'm so sorry, I heard your child has a brain tumor." No, you have to say. Neuroblastoma is not a brain tumor, even though its first name is neuro, which would make a lot of people think that it's a brain tumor. In fact, neuroblastoma is a tumor of what's called the peripheral nervous system, so the nervous system outside of the brain. And as you can see in this diagram, the peripheral nervous system runs basically next to the spine, and you can see its nerves, nerve roots, and the adrenal glands comprise the peripheral nervous system. And so what you get are tumors primarily in the abdomen, most commonly in the adrenal glands. As you can see in the slide, the arrow on the lower, I guess that's your right, is an adrenal primary. And up above, the two big red arrows on either side of the spine show disease along what's called the sympathetic chain. And those are common sites for neuroblastoma in the body as part of the peripheral nervous system. Why does that happen? Why does neuroblastoma end up in the peripheral nervous system along the sympathetic chain next to the spine and in the adrenal glands? Well, it turns out that neuroblastoma cells come from what's called the neural crest in the developing embryo fairly early on in the development of what's going to be a baby. And the neuroblastoma cells migrate, the neural crest cells start, is this a pointer? Well, maybe it's not, but think about the head of this little tiny, oh, I can walk. This cells start here and migrate basically along the back. And in an orderly progression, in many of us, the cells migrate down along our spine and land at the adrenal glands, which is pretty amazing when you think about it, that those cells migrate, they know where to go, they know when to stop, they know when to divide and not to divide, and most of the time it works out just fine. But in the case of children with neuroblastoma, that migration and that starting and stopping and moving and staying still gets messed up in whatever way that we don't completely understand, and you end up with neuroblastoma tumors. Sometimes those tumors will migrate and forget to stop dividing and end up next to the adrenal gland as a localized tumor. As you can see, there are two kidneys sitting on either side of the spine, and below the one on the left is a tumor. That's the neuroblastoma. But sometimes more happens than that. In the next two pictures, you can see that above the left kidney, there's something sitting on it. That's a neuroblastoma tumor. But cells also migrated in the liver and forgot to stop dividing and grew and multiplied. And now there's a liver full of neuroblastoma cells. And in the slide on your left, there you can see almost the whole abdomen is full of tumor, and that's a very small baby with a very big liver full of neuroblastoma cells. Why did the first child in the top part develop just neuroblastoma in one spot, and why did the child in the second set of slides develop disease that's both in the liver and next to the kidney? We're beginning to think we understand that, but we don't completely have it down. But those are two of the faces of neuroblastoma. Many of you in the audience will have experienced a situation more like this last set of slides, a child who not only has a tumor in the abdomen, but the cells also have migrated to other parts of the body, including multiple bones, lymph nodes, and the colorful panel is disease in the bone marrow. So these are many different, what we call clinical presentations of neuroblastoma, but it all comes from the neural crest and these errors or mistakes in migration and cell division. So when does this happen? Where does this happen? Why does this happen? To me, this idea of developmental biology going slightly wrong is intriguing, and it's something we really need to understand why neuroblastoma happens. And we're trying very hard as a community to understand what happens at the cellular level, what are the signals that get confused, to try to understand the start of your child's neuroblastoma. But we do think that this complicated developmental process is at the root of it and explains why neuroblastoma can behave in so many ways. And what's really interesting for us as clinicians is that neuroblastoma sits at the crossroads of so many parts of science: developmental biology, pharmacology, radiology, immunology, cell signaling. Any part of science that you can think of touches on neuroblastoma. So we have to really come together to think about why neuroblastoma happens and what to do about it. So when we see children with neuroblastoma, we see the little baby sleeping peacefully in this picture. And this little child had a relatively small adrenal mass, never required any treatment, and her mom allowed me to use this picture, but perfectly fine, no surgery, no radiation, no chemotherapy, just observation, and this child is beautiful and doing great. Another patient whose mother also kindly let me use this photo presented in a very different way. Some of you may have seen your own child or another child with involvement of the bones around the orbit and that black and blue appearance, sometimes referred to as raccoon eyes. This little child had a much more complicated abdominal tumor and involvement of bone and bone marrow, and she was treated with multi-modality therapy, including chemotherapy, surgery, MIBG therapy, high-dose chemo with stem cell rescue, radiation, immunotherapy, Accutane as differentiation therapy, and unfortunately her outcome was not as good as some of the other children with neuroblastoma. So how can this be the same disease? How can you have one child who requires essentially no intervention and does fine, and another child who receives every treatment that we can possibly think of and unfortunately did not survive her disease? And when we talk about it in the same breath. We call them both neuroblastoma. That seems unbelievable, but it's true. When you look under the microscope, those cells look the same, but we all know that they're really not. So there's a long history of research that helps us understand this conundrum, this confusing fact that neuroblastoma can behave so differently. So we have long been able to look under the microscope at the cells and say those cells look more aggressive, more packed in, less grown up, less differentiated compared to some of the other cells. So that's pretty simple looking under the microscope, but still important. In the 1980s, Gerrit Brodeur, Manfred Schwab, and others uncovered the fact that there is a gene that drives a very aggressive kind of presentation of neuroblastoma. And when you have too many copies of that gene called MYC-N, the cancer often can behave in a very aggressive way that you might not have been able to explain simply by location, presence or absence of metastatic disease, or the appearance under the microscope. So this was the beginning of the idea that something is driving neuroblastoma that our eyes can't immediately see. So MYC-N opened the door into thinking about tumor biology. Around the same time, we started to understand the importance of looking at the DNA content in total, and we learned that patients who have different amount of DNA in their cells might have different outcomes with the same therapy administered. So this was old news back in the 1980s and early 90s, and the exploration and discovery has continued to this day. So what this looks like today is beginning to look at changes in the DNA sequence of tumor cells over time, whether through biopsy of tumors that respond to therapy and then come back, or looking at liquid biopsy that you'll hear a lot more about from my colleagues later today. But this has really come a very long way in looking at a single gene versus sequence changes in many genes in neuroblastoma cells. In addition, we're looking beyond just gene sequence and looking at all the other complex things that happen in the body as DNA encodes RNA, encodes proteins. Those proteins are modified. There's so many other levels of inquiry that some of my colleagues sitting at the table are very interested in and teaching us every day about the biology of neuroblastoma. If this seems complex and overwhelming, it's because it is, and I won't spend more time on this today, but invite you to the ANR, Advances in Neuroblastoma Research meeting that happens every 2 years. And this is where we sit and learn from our basic science colleagues about really what's happening on the molecular level in neuroblastoma and how does it apply to patient care. But let's get back to basics. I got a little far afield there. When a patient comes in the year 2025, the first thing we do is a biopsy to understand, is this really neuroblastoma? It walks like a duck and quacks like a duck, but is it a duck? We better prove that. And so in most children's cases, we'll get a diagnosis, nowadays usually with an interventional radiology procedure, but sometimes still with a surgical biopsy. And we look under the microscope and say, behold, this looks like neuroblastoma. Getting enough tissue is really important for all the complicated studies that we need to do to understand the biology of the tumor and how it might behave. So we want to do these key profiling studies for therapy selection. This is the usual dogma, do a biopsy, learn more, but there are certain cases where we don't want to do a biopsy or we shouldn't do a biopsy. And the first one is that little baby I told you about who had a small adrenal mass noted right after birth. No biopsy indicated, and that patient is fine. And that's a very specific group of young infants. There are other infants who come in, like the patient I also showed you before, with a belly full of tumor, mostly liver, but you can see that that patient probably is not feeling well, not doing very well. And there's some patients where we don't biopsy and we just have to use our clinical judgment and say, let's start this patient on treatment. We'll get a biopsy later when it's safe. So that's another presentation that you might have heard of or experienced. In the future, I would hope that we can use some more sophisticated and less invasive techniques to be able to learn more about the tumors of those children I just told you about, but also about the other children who might not actually 5-10 years from now need a tumor biopsy, but instead perhaps be able to undergo a liquid biopsy, identify that this is neuroblastoma, identify some of the genes that are most important in determining how to treat the patient in a less invasive, easier on the child type of way. So that's just a little glimpse into the future, I hope. The second thing that happens after the establishment of the diagnosis is to do what's called staging. So figure out where is the tumor in the body. And typically that means looking at the main site of the tumor or the primary tumor, generally with a CT or an MRI scan. In addition, we look at sites where the tumor has spread, metastatic disease, with an MIBG scan, or in the rare patients whose tumors don't light up on MIBG scan, we can do what's called a PET scan. And finally, we look at bone marrow, which is difficult to tell on an MIBG scan or difficult to tell on a CT or MRI. And we actually do a minor procedure where we take a little sample of the liquid part of the bone and a little piece of bone marrow surrounded by bone and look at it under the microscope to determine if tumor has spread there. Based on all of those tests, we assign a stage. Localized tumors can be either pretty simple and just a circle, looks like a golf ball or a grapefruit sitting in a child's abdomen, as you can see in the slide labeled L1. And a surgeon would look at that and say, let me at it. I want to take this out. This would be a great thing to do. I can make this kid better. And then the second panel down below, L2, is where a surgeon says, do I have to? You really want me to go after that? That's a more complicated tumor that's wrapped around structures in the body and needs a different approach rather than a quick operation. Those are localized tumors, L1 and L2. Then we come to M, which stands for metastatic. So those are patients who have tumor that has spread to bone, distant lymph nodes, or bone marrow. And then finally, there's a special case called MS. The S is for special. And those are very young children, typically under 18 months of age, and have a particular pattern of sites that Meredith, I think, will mention to you, based on very keen clinical observations made by Audrey Evans many years ago. So these are basically the 4 stages. We don't so much talk about 1, 2, 3, and 4 anymore, but typically L1, L2, M, and MS. And then we put the information that we have together to talk about what is the risk of relapse for this patient. So many of you have heard of a child who has intermediate risk disease or high risk disease. And so that process of assigning that category is called risk stratification. Most of the children who need a lot of therapy and most of the children who go on to relapse have high risk disease. But it's important for us to remember, especially those of us who spend so much time thinking about high risk and relapse neuroblastoma, that about half of the patients that present with neuroblastoma have non-high risk disease, have low risk or intermediate risk disease. And it turns out that those patients generally do very, very well. So we just don't want to get so focused on relapsed or high risk disease that we forget. Determining a child's risk group is absolutely critical, sort of from the Goldilocks point of view. You don't want something that's too big or too small. You don't want to undertreat someone who needs high-risk treatment. You don't want to overtreat a child who actually has intermediate risk disease. You don't want to give them high-risk therapy because that comes with a lot of short, intermediate, and long-term side effects. So getting it right from the beginning is really, really important. Some of the factors that come into play are the age of the patient, and the under-over is 18 months. The patient's stage, as I just mentioned, how it looks under the microscope, called histology, the presence or absence of multiple copies of the MYC gene. Remember, that's from way back in the 1980s, and still stands today as a very important prognostic factor and factor that helps us with risk classification even now in the 2020s. And then currently we use the presence or absence of additional pieces of chromosomal material known as segmental chromosome aberrations. And some of my colleagues will talk about that a little more in detail with regard to risk classification. But these are the things that we use today in 2025 to determine whether someone has high risk, intermediate, or low risk disease. And here's my favorite figure by none other than Meredith Irwin sitting in the front row. But I look at these tables from this paper. I've been doing pediatric oncology for 25 years. I take care of a lot of children with neuroblastoma at the Children's Hospital of Philadelphia. But I still look at this paper probably at least once a week, I would say. Because sometimes it can be really tricky. A lot of times it's very straightforward to assign a risk group. So a child over 18 months of age with metastatic disease has high-risk neuroblastoma. That's not very intellectually challenging. It's therapeutically challenging and emotionally challenging, but assigning risk is not that hard. Same thing with a little child with a easily surgically removable tumor and no metastatic disease. That's low risk. But sometimes it can be very tricky and you have to think about all these different factors that come into play in assigning the risk group. So no shame in using our colleagues' diagrams to help us make the right call about risk. Sometimes there are really significant challenges, and a lot of times we have to wait for additional results from, for example, from DNA sequencing studies or other studies to help us make a decision about which risk group should a patient be in? And this, from a parent's perspective, is simply terrible. They want to know what's going to happen next, and sometimes we have to all take a deep breath and kind of pace with it until we have all the right pieces of the puzzle to assign risk properly. Sometimes we have to give some therapy in an urgent or emergent basis while we're waiting for all the information to come in, again, to assign risk properly. And there are sometimes patients who have unusual clinical presentations, and I don't say the patient didn't fit the algorithm. No, the algorithm didn't fit the patient. The patient has what they have, but we as clinicians sometimes have to really puzzle about what to do. So the patient with the mass in the chest, whose arms are up like this and has a big mass pushing on their windpipe, presents a certain scenario where they might technically fall into a higher risk category, but with a brave surgeon and favorable biology, might not fall into the high risk group that one might think originally. And another patient in the panel on the left had a very complicated tumor, and some road signs might not point towards high-risk therapy, but some of the other characteristics might point us in a different direction. So there's some situations where risk classification is very straightforward, and other times where we really have to scratch our head. And you may hear of a physician talking to their colleagues, consulting with others in the neuroblastoma community, because it's so important to get it right. And again, there's no shame in that, just like there's no shame in checking the algorithm, because we really just want to do the right thing by each and every complicated patient. So that's me at my computer emailing some of the people you'll see for the rest of the day. It's important to understand that risk stratification has evolved over the decades that we've been applying a risk stratified approach, and it's going to continue to evolve. So this figure is from the paper, where's Lee? Of one of our colleagues who will be speaking later today about new imaging technologies. So this is using an MFBG tracer rather than an MIBG tracer. And it gives beautiful pictures, but may also pick up additional sites of disease that we didn't appreciate on the technology that we have been using. And this is really important because we may have a patient that we thought had localized disease. We pick up something new with our fancy tracer, and now we say they have metastatic disease, but the implications of that aren't totally understood yet. So we have to take new technology, be excited about it, but also be thoughtful about what does this mean for the patient in front of me, and what does this mean for how I think about risk for that child. The same is true, again, of liquid biopsy. It's very attractive because we would like to have fewer kids need to get scans all the time, need to get bone marrows, but we need to understand how to use it wisely before we start doing tests and then end up with information that we don't understand. So risk stratification will evolve, and I think these new technologies will be incorporated probably within the next 5 years or so, but we have to do it step by step and be smart. So I'll briefly go over our approach to treatment, and then many others will talk much more than I will. But to address non-high-risk disease, the biggest move in the last 10 to 20 years has been to reduce the potential for harm. So many patients in the battle days were treated much more aggressively with their low and intermediate risk disease, and we don't want to cause any more trouble for those patients in terms of late effects than they actually need. So some patients don't need any treatment at all. Some just need surgery. Some need a little bit of chemotherapy to get them over the hump, and they're going to be fine. And some need a combination of chemotherapy and surgery, and you want to be smart about how to use those tools to minimize the likelihood of late toxicity. We want those kids to grow up and be completely well. On the other hand, high-risk disease is a much different kettle of fish. This is a Kaplan-Meier curve, which you may see throughout the day, and what it shows on the x-axis are the years from diagnosis, so that's time, and on the y-axis is event-free survival, and that's generally speaking survival without relapse, with a few exceptions, but we'll go with that. And what you can see is over time, in the lowest curve, the solid line from the 1990s, From the time of diagnosis up through year 5, the curve drops off very steeply because in the first few years from diagnosis, children relapsed quite quickly, and the survival rates were truly terrible, just over 20% at 5 years. And I'm not going to tell you exactly when I started in this field, but the curves were pretty bad when I first started, and what I said when I first started treating patients was about 25% of patients will be alive and relapse-free at 5 years. That's a very different story to what we say now, and you can see incrementally the curves have gone up, up, up. And so the most recent data that we have was from 2015 to 2019. You can see that the curves still drop off, and at 5 years, the event-free survival is just over 50%, which is truly not where we want to be. But appreciate where we've come from. So the event-free survival going from 25 to 50% is a real improvement. Like, that's double what it used to be. And I think everyone in this room would like to see it double again before we walk out of here and say, job done. So we still have a really long way to go, but we've really made significant improvements. And that's through an approach that I'll explain to you right now. However, it comes at a significant cost. And many of you have sat through a conversation about high-risk disease, and sometimes a little bit you are just so focused on what do I need to do next for my child, and sometimes you're able to hear and think about some of the late effects of high-risk therapy, but there are many. And we're just beginning to appreciate in a real way what those side effects are. So hearing loss is a significant issue. More than half of kids in the children's oncology group experience with high-risk therapy develop hearing loss that's significant enough to need hearing aids. Some patients have renal dysfunction, growth issues, fertility issues, other kinds of issues like second malignancy, which is thankfully quite rare, but not zero. So we have to really think about how far we've come, but we also have to think about the toxicity that we expose children to and try to do better with both of those aspects. We have a long-standing paradigm on both sides of the ocean that includes intensive induction therapy designed to decrease the disease burden, primarily through chemotherapy and surgery. Consolidation therapy means that you're digging your heels in. You've made progress, and now you really want to firm that up. And that's typically done with high-dose chemotherapy with stem cell rescue to help recovery, and radiation as well. And then post-consolidation, harnessing the body's own immune system to fight any neuroblastomas cells that might be left behind. And that paradigm is the same in many parts of the world. However, this paradigm has recently evolved, and I think there'll be some discussion today about that evolution. There continues to be induction, consolidation, and post-consolidation of different flavors, but we are still trying to learn more about what agents and what timing might impact the outcome. Does early introduction of targeted therapies like ALK-directed therapy, MIBG, other agents, does that make a difference in our initial response to chemo and in our long-term outcomes? Is high-dose chemo with stem cell rescue still required? And I know that's a very hot topic, and we'll talk about it probably through the day. Radiation. We kind of sometimes gloss over radiation. Sorry, Mark. But what sites should be radiated? What dose should be used? Those are really important questions in our field. Which patients truly benefit from immunotherapy? It's now been adopted across the board in most institutions on both sides of the ocean, but we still don't know really which patients get maximal benefit from immunotherapy and which just experience toxicity. And now in the modern era of immunotherapy, could we subtract some of the other things that we administer to children? I think probably so, but we still don't know which ones and in whom. So lots to learn. And then finally, what about continuation therapy? So a child goes through all this treatment and then suddenly they're done, but can we improve survival by adding additional therapy onto the end? So continuation like vaccine therapy, DFMO, or perhaps other agents. So lots to talk about. We have so many questions and we need the expertise of everyone. We need surgeons, we need radiation oncologists, we need our pediatric oncology colleagues from around the world. We need pharma, we need our drug companies to be on board with us for sure, and we need our regulators, the EMA, the FDA, all the other people who help with drug development and drug approvals to also be on board. We need our laboratory scientists to continue to help us understand the biology of neuroblastoma and test new approaches, new drugs. And finally, and really importantly, I stole this from the SKC website, we need you. We need the parents, we need the families, we need your inspiration, your thoughts, your opinions on what really matters and what doesn't. So it's really got to be a community effort to try to improve the outcomes and also decrease the toxicity that kids are exposed to. If, again, shameless plug for ANR, if you have found this little preview interesting, and if you are even more interested throughout the day, please join us. There is a parent component to the ANR meeting in May. Oh, and take homes. That's
Thank you very much, Ro, for an incredible, excellent overview of a very complicated topic. So I'm sure there will be lots of questions, which we'll take after the next talk. So it's a really great pleasure to introduce Juliet Gray, who's the chair of the UK Neuroblastoma Group and also the chair of the CEOPEN, so the European Neuroblastoma Clinical Trials Group. Juliet spends an awful lot of time thinking about post-maintenance, so maybe stopping it coming back is the best way of thinking about it. So Juliet spends a lot of time and is probably the European leader on that, so we're very happy to hear her speaking. Thank you, Juliet.
So thank you, Cormac. It's wonderful to be back here again and lovely to see so many people. So what I would like to do in the next 20 minutes or so is pick up where Ro left off, one of the big dilemmas and uncertainties that we've been kind of talking about and working on over the last year or two is, could we enhance treatment anymore by giving more treatment after maintenance therapy? So this just applies to, at the moment, to children with high-risk neuroblastoma. And here we've got the current paradigm of treatment, which, as Rose said, is very similar on both sides of the Atlantic, with induction chemotherapy to try and reduce the bulk of disease, high-dose chemotherapy with stem cell rescue to try and consolidate that, surgery and radiotherapy to control the primary tumour, and then a period of immunotherapy and retinoic acid to try and mop up any cells that are left after all that treatment, and also the retinoic acid to try and differentiate into more mature neurons any cells that are left. The subject of this talk is whether we can build on that and improve outcomes of children more by giving further treatment after this long period of intensive therapy. So really to set the background for that, we need to think about what the outcome of children are when they finish treatment rather than at the beginning. So as Rose said, for children who are newly diagnosed with high-risk neuroblastoma, around about 50% of children will be cured in the long term. However, this graph here is the same sort of Kaplan-Meier curve that Rose showed before with the event-free survival, so the percentage of children who don't relapse on the y-axis, is taken from the end of treatment when children have got through all the hurdles of that high-risk treatment, their induction, high-dose chemotherapy, immunotherapy, and have had a good response to that. The children at the top in the blue, the navy blue line, is the children who have achieved a complete remission with that treatment by the start of immunotherapy, and that shows their outcome, event-free survival from the end of treatment. And for those patients who have been in complete remission at the start of immunotherapy, their 5-year chance of not relapsing is about 80%, which is substantially better than at the beginning and at diagnosis because they've got through all those hurdles of treatment. The red line is those children who hadn't achieved a complete remission at the start of immunotherapy, so still had some disease on scans, And you can see that the event-free survival for those children is lower, but still many of them are long-term survivors. So it's important for any new treatment that we look at that comes after the current treatment, we're comparing it to these figures rather than the 50% figure or numbers in that ballpark that we talk about at diagnosis. And that can be really difficult for several reasons. When children reach the end of treatment, they haven't got any disease to measure and monitor. And for any individual child, although we know if you look at all children, that's the outcome, you don't know what will happen to that child. And when you give a treatment to the child and there's no disease to measure on scans, all you're looking for is whether the disease comes back. There's nothing to shrink in terms of tumour that can reassure you that the drug you're giving is having some benefit. The other thing that makes it challenging is that when relapses do occur, they often happen in the first few months after treatment, and so the starting point for where you start any new treatment at the end of the kind of current maintenance treatment is really important, because if you don't start that treatment till a few months, say 3 months after you've finished current maintenance therapy, even by then, the prognosis for that child is better than at the exact time point they finish treatment if they've not relapsed during that time. So the further time goes on, the better the prognosis gets. So the exact time point that patients are recruited to any post-maintenance trial to look for whether such a treatment works is really important to assess whether it's of benefit. So the question that we have faced is, can we improve those percentages anymore by giving a further period of treatment after finishing anti-GD2 immunotherapy? And there's been two things that have been investigated most internationally. The first is a vaccine. It's a bivalent, so it targets two different things, GD2 and GD3. It's the same GD2 that's used in the GD2 immunotherapy. And it's the aim of that is to make the child make their own GD2 antibodies by immunising the child, and then DFMO. And I'll talk about both of those and what the evidence we have for each of those is in this setting. So firstly, the bivalent vaccine. So the scientific rationale for this is very strong, that if you can, that we know that antibodies work. They don't cure all children, they improve outcome, but don't improve all children. And then we know that the more antibody you give, probably the better that is. And the rationale is if you can immunise, the body makes their own supply of antibody, and then you have permanent low levels of antibody, giving the child their own immunity to the neuroblastoma. In the antibody that's been tested has been developed at Memorial Sloan Kettering in New York, and it's given with other things as well as the GD2 and GD3 to try and boost the immune system, to try and make an effective immune response. The GD2 and GD3 molecules are not easy things to immunise with. They're different from bacteria and viruses, which are used in the standard vaccines, and so they need to be given with other things to make them effective as vaccines. And in MSK, they have used it with beta-glucan, which is a product that's taken by mouth that is derived from yeast, and sometimes with GM-CSF, which is an injection to boost the immune system. And what they have done in MSK is given multiple doses of the vaccine, initially over a period of a year, but now that's been extended, and they give booster doses up to a total of 3 years with the beta-glucan to boost the immune response. The largest study that they have reported was in children who had relapsed from their high-risk neuroblastoma and then got back into a complete remission. And so that is already a slightly a selected group of patients. So not all children with who have high-risk neuroblastoma that relapses will get back into a good complete remission, and so we have to bear that in mind with the percentages that we see there. They're not survival percentages from the point of relapse; they're from the point of having achieved a complete remission and starting the vaccine. And what they did show with the vaccine was that there was very minor side effects, so sore arms, some temperatures when the vaccine had been given, but generally it was very well tolerated. They were also able to demonstrate that the majority of children who had the vaccine, about 80%, had good immune responses to it, so you could measure the antibodies in the blood of the patients. But what has been more difficult to show is whether the vaccine is actually effective. And that's for all the reasons that I've said, that all of these children are in remission at the point of having the vaccine, and we don't know what the outcome of those children would be if they'd not had the vaccine. So there's not a really good comparison group to say that the vaccine is better than not giving any more treatment. The percentage survivals that they report from this study were very good. So with overall survival rates of 88% at 2 years and progression-free survival of 45% at 2 years in children who had relapsed. But again, this is a selected group of patients who have achieved another complete remission having relapsed. What they did show is that in those children that were treated, those children who developed a good antibody response did have a better survival, which does support the hypothesis that if you can generate an immune response, then it's beneficial. But all of the children in the study were given vaccine, and so there isn't a good comparison, so we don't have any definite evidence that this is improving survival, but the scientific rationale is there and it is safe. So the vaccine is still being trialled at Memorial Sloan Kettering, and I think they have 2 trials open at the moment, both for patients who have completed first-line treatment or have achieved a complete remission after relapse. Patients have to be in complete response when they're given the vaccine. If they have MIBG-positive disease, that has to be PET negative, so they can have some MIBG spots, but they have to be PET negative, and they have to be within 6 months of finishing any other treatment. And in the trials that are happening in MSK at the moment, I think it's been given with beta-glucan and GM-CSF, and those are all single-arm trials where all children get the vaccine, and it's only available in the US. So the alternative treatment that has been most explored in a post-maintenance setting is DFMO, which is also known by these other names. It's a tablet that is taken by mouth, and it's a tablet that inhibits ornithine decarboxylase, which is a complicated part of a complicated molecular process that happens in cells to generate polyamines. And that process can be overactive in patients with neuroblastoma, particularly those that have MECAN amplification. And the idea of this DFMO is that you block that enzyme, reduce the polyamines and starve the neuroblastoma cells of the polyamines. And in the laboratory, that this approach has been shown to slow the growth of neuroblastoma in test tubes and in mice. It's a well-known drug in other contexts. It's been used since the 1970s for sleeping sickness in Africa, and it's been shown to kill the sleeping sickness parasites. And it's been investigated more recently as to whether it has a role in controlling neuroblastoma. So the largest trial that's been done for this was done by the Beat Childhood Cancer Trial, which ran between 2012 and 2015. And this, again, all patients got the treatment. All patients were in remission when they received the treatment, so it's very difficult to know whether it was having any direct effect on any tumour cells. About 100 of the patients treated had just finished first-line treatment and were in remission, and 39 patients had achieved a remission having had a relapse or refractory disease. And patients who were recruited had to have achieved at least a partial response to previous treatment, and any disease that was left had to be PET negative. And they had to start treatment within 4 months of treatment. In the trial, the treatment was given, the DFMO treatment was given by mouth twice a day for 2 years, and all patients received it. There was no randomisation. And again, they reported very good survival figures. For frontline patients, the 2-year event-free survival was 84%, and overall survival was 97%. But again, you have to put these in the context of these were patients who've completed their frontline treatment, were in remission, and so you have selected a better population of patients than at diagnosis. For relapse and refractory patients, they also reported very encouraging survival rates rather than response rates. In the trial, the DFMO seemed to be very well tolerated. The majority of patients in the trial completed the 2 years of treatment, which kind of suggests that it was tolerable and patients managed to take it. Of the 101 patients who had who'd finished frontline treatment, the 79 of them completed the 2 years of treatment, and only 5 who didn't stopped it because of parental choice or of side effects. The others had stopped it because they'd had a relapse of their disease. About 2/3 of the patients who were on the trial reported no side effects at all. And the side effects that were seen were generally quite mild. The main side effects were some liver toxicity with high levels of liver enzymes in some patients. But in general, these were mild, and dose modifications, so reduction in the dose of the DFMO was only needed in 2.5% of patients, and only 1 patient had to stop the DFMO completely because of problems with their liver function. It can cause mild nausea and diarrhea, but generally this is tolerable, and children were able to continue the DFMO. It can cause low blood counts, but again, it was rare in the trial to have to stop or reduce the dose of DFMO because of this. Probably the side effect that has caused the most concern has been hearing loss. And as Ro mentioned, a lot of patients who have been through high-risk neuroblastoma treatment have hearing loss anyway because of the amount of cisplatin treatment is in the treatment. But in the trial, they reported that 7% of patients required a hearing aid after or during the DFMO treatment who didn't at the beginning. And I think about 12% there was some deterioration in their hearing during the course of the 2 years. But in most patients, in I think 9% of the patients, this was reversible when the DFMO was stopped. But it is something to be aware of. So there are no randomised trials of DFMO. We just have this trial where it was given to all patients, which makes it difficult to interpret the data. But what has been performed is a matched comparison, so not a randomised trial where children are randomly allocated to a control treatment or the DFMO, but the children in the DFMO trial were matched with similar children in the main COG trial that ran at the same time period to try and match the individual characteristics of the children who had DFMO with those who'd been treated in a parallel trial where children were not getting DFMO. This is not the optimal way of assessing to get definite evidence of whether a new drug works, but it was the best that could be done with a single-arm trial. And what this showed with this really complex and thorough analysis, the blue line at the top is the event-free survival of those children who'd had DFMO within the trial, and the red line below is those who didn't have DFMO and were treated in the other trial. And it showed a roughly 12% difference in 2-year event-free survival between the two. But it has all the caveats of this wasn't a randomised study and is subject to all the risks that brings. On the basis of that matched analysis, the DFMO was approved by the US Drug Agency, the FDA, in October 2023, and it is now available in the US. In Europe, the company Norgine has acquired the drug and is applying for approval from the UK and European drug agencies, the MHRA and EMA, and those are still being reviewed, and we don't have the outcomes of those yet. While that is taking place, Norgine have started an expanded access programme to make, in the UK at the moment, to make DFMO available free of charge to patients through their programme, pending the MHRA EMA approval. For patients, so patients in the UK can currently access DFMO through that route. It has to be within 4 months of finishing standard treatment. And patients have to have had at least a partial response to multimodal therapy. They don't need to be PET negative, they just need to have had a partial response, which is in line with the FDA approval label. Within the expanded access program, they cannot take any other cancer treatments, they can't take any chemotherapy, they can't have the vaccine or anything else at the same time. So achieving approval from the drug agencies is the first step to being able to use it as a standard of care. The second step is that there needs to be funding approval from, in the UK, from the NHS, to show that not just is the drug safe and effective, but is it affordable, and is it the cost of providing it to children in the UK is warranted for the level of evidence is there. And that process, which is called the NICE appraisal, is taking place in April, and they will review all the evidence and make a decision as to whether the drug can be prescribed through the NHS. But the Norgine Expanded Access Programme will run until the outcome of that is pending. We don't have any data about giving DFMO after the European treatment regimen, which is slightly different from the US treatment regimen. And so we will aim to collect information about children in the UK and Europe taking DFMO. In the UK, we've asked hospitals who are giving DFMO to children onto the Expanded Access Programme to collect some data about that, about any side effects children get and how children do. And we hope that we can amend the current high-risk trial in Europe, the COP1-HR2 trial, to collect that information so that we know we can get more information about whether it is of benefit to give DFMO to children in Europe. So the DFMO comes as a tablet. It can be swallowed, crushed or chewed, so it seems to be okay to take, and again most children in the trial managed to take it for 2 years without stopping. There was initially lots of discussion about whether it should be given with a low polyamine diet. In the trial that wasn't enforced, and there wasn't data collected on as to whether that was had any influence on the outcome of children, and it's not part of the FDA approval or the Expanded Access Programme that children need to follow a low polyamine diet with. So we don't have any. There's theoretical benefit that if you reduce polyamines even further by cutting out the diet, you could improve outcome, but there is no direct evidence for that, and it's not a stipulation of the Expanded Access Programme. Children do need to have some blood tests while taking the DFMO. They need to have blood count, liver function tests at the start, monthly for the first 6 months, then 3 monthly for the rest of the 2 years. They need to have hearing tests done at the beginning and then 6 monthly during the treatment. It doesn't influence what scans children need. They can have the normal standard of care scans they would have been having anyway. So I think the question that people are facing is whether their child should take DFMO, should go and seek the vaccine, or should stop treatment, and I think that can be a really difficult decision to make, and there's lots of different things to weigh up. We don't know the amount of data for DFMO is relatively limited, and we don't know what the benefits are for different children with MICN amplification, not with MICN amplification, children with some disease left at the end of treatment. All these different situations, every child is different, and we don't know the benefit for any individual child. It does prolong treatment considerably, an extra 2 years of treatment with more blood tests, injections, trips to hospital, the risks of side effects, having to take a medicine every day for 2 years, and the risk of side effects, although we hope the risk of those is relatively small. For seeking the vaccine, there's also the additional burden of travel and cost. And so, just to summarise, I don't think we can give any mandate as to what families could do or strong recommendation what families should do. That has to be an individual decision for families that their physicians can support them with. But just to summarise what we know about each of those different options, for the bivalent vaccine, we know it's safe, the side effects seem to be mild, it does generate an immune response, and if you get an immune response, that seems to have a beneficial effect on outcome. There's promising data for the single-arm study, but all those patients are in remission. We have nothing to compare that to, and there's no randomised trial. It is a lot of extra injections, and it prolongs treatment, and there is a significant cost and burden of travel for families seeking it. For DFMO, we know it appears to be safe, it's generally well tolerated. There is a small risk of worsening hearing, but we think that improves when you stop treatment in most patients. It does prolong treatment by 2 years. There isn't randomised data, but the data from the matched comparison was sufficiently robust for the FDA to approve it. So there is some level of evidence, and it is currently available in the UK without any cost to families. There is no data at all to directly compare the vaccine with DFMO in terms of helping families to choose one over the other, or neither. I think that's all I had to say. So thank you very much, and I think we'll convene as a panel for questions.
Thank you very much, Juliet, for a great overview of a challenging but very important topic. So yes, if you could take a seat in the panel, and I'd like to invite Ro to come back. I would also like to invite Dr. Aditi Vedi to come up. Aditi is a paediatric oncologist working in Cambridge. And I would also like to ask Naomi Sheffer-Thomas and Mandy Berriman, who are parents and advocate members of the Neuroblastoma Committee. So thank you very much for coming up. I think one of the great things about this meeting is the people who have been invited to come, who have agreed to come. It really is a stellar list of excellent physicians, researchers, advocates, and I think SKC is, well, it is. I definitely think it's the best advocate group in the world for neuroblastoma. So I think it's a really excellent group of people that we have here who are going to answer lots of questions. So we're going to take some questions from the floor, but I would like to ask Juliet just maybe an explanatory question. So you mentioned in relation to DFMO that it was a single-arm trial and it's very difficult to interpret that data. Could you maybe explain the concerns about looking at results from that type of trial or retrospective analysis?
So I think microphone on. Better. Can you hear that now? So I think we've heard how different children with neuroblastoma are, and even within high-risk neuroblastoma, there is a big variation in the features that patients have and how they respond to treatment, the genetics, the response to treatment, where the tumour is, the age of the patients. And so for the gold standard for any treatment to prove whether it is beneficial is to do a randomised study where children are randomly allocated to either the standard treatment of the time versus the new treatment. And then you can be confident that any benefit and difference you see is genuine and not just due to how you selected your patients. And that's particularly important if you've got children who are in remission. There's nothing to follow on scans, so you can't see that the treatment is making tumours shrink. And also at a time point you're starting it where there's a very steep curve for when relapses happen. So the time point when you recruit patients to these studies is crucial, because if you don't recruit patients till 3 or 4 months after their treatment is finished, already by then their prognosis and their chances of not relapsing is better than when they finish treatment, and certainly better than at diagnosis. And you have to, if you do a randomised study, you match that completely. If you do a single-arm study, everybody gets the same treatment, then you try and retrospectively match those. But that, although you can, it was done incredibly thoroughly within the DFMO matched analysis, and as thoroughly as it could be done, but there's still potentially some factors you can't account for, such that the children who go and sought DFMO might not be the same treatment. There might be children who've had a better time during their first-line treatment. They might be more affluent children. There might be children who are able to travel, well enough to travel, who've had a side effect. And you can't match completely for every single factor like that. So it's really difficult, but we are in the position we are. We have the data we have, and it would not now be possible to do a randomised study because we have that data, and I don't think anybody would probably want to take part in a randomised study at this point, but it would have been really nice if we'd done that 10 or 15 years ago.
Thank you, Juliet. So can we invite some questions from the floor? We have 2 runners, so I'm going to ask you to wait for the microphone to ask your question. So we have a question in the middle.
Hello. Hi, my name's Carrie, and this is my daughter Lucy. One of the questions I had was for you, Ro. You mentioned in your presentation about the MFBG scanning in place of MIBG. Can you talk to us a little bit more about the benefits of that, and also where it is, because obviously we're here in the UK still using the traditional MIBG. We do have SPECT CT, but they don't shout about that because obviously it's costly. So if you shout loud enough, you can get a SPECT CT, speaking from experience. You mentioned in your presentation that potentially the MFBG shows other areas that you were unaware of at the time, but surely that can only be a good thing. So how far off are we from having something less dated, less old-fashioned, and far more reliable for detecting disease in our children?
Yeah. Is my mic on?
Not yet.
Okay.
No.
Oh, now it is. Okay. Great questions and really important questions. So the benefit of MFBG from a patient-family experience point of view is tremendous. So as many of you know, MIBG is a 2-day procedure. So you get injected one day and take pictures the next. And so if you live a long way from your treatment center, now you have to go 2 days in a row, or you have to stay over. And that's really a lot of time from work, and it's a lot of travel, and it's annoying. The other issue with MIBG is that it requires thyroid protection because the thyroid gland loves iodine, and MIBG is an iodine-based tracer and can cause damage to the thyroid. So you get to take, Lucy can probably say, those nasty drops, and different institutions do it differently, but it's multiple days of drops. And with MFBG, there's no eye, and so you don't have to take those nasty drops. In addition, the MFBG scans are much shorter. So for a good-sized child even, the scan can be done in a relatively short period of time, like 10, 15 minutes, rather than 45 minutes for the whole body images and then an extra 45 minutes for the SPECT. And that's really important for the younger children because we're having to put them to sleep so they can hold still for that long time of the MIBG study. And there's the potential that fewer kids would need sedation for MFBG scans. So for all of those reasons, this is really, really attractive. The pictures are pretty too, like, let's not lie. It's not just dots on a screen, but they're these very nice, sharp looking scans. The problem is, oh, there you are. Liev has done a lot of this work, so I even showed a picture from your paper. And feel free to chime in. The problem is that we don't necessarily know what those extra spots mean. And I worry about the assumption that it's only going to be good to know, because the fact is we're just in a data vacuum at the moment. So if I have a known primary tumor and no metastatic disease on my bone marrow or on my MIBG scan, I may have a complicated tumor and have L2 neuroblastoma. In this moment, I don't know from an MIBG scan if I have metastatic disease. If an MFBG scan shows that I do, there's a possibility that that disease was missed and was important, and my prognosis might have been worse. But it's possible now that I might be overtreated. Like, I might get a lot more therapy than I actually needed just because now this little spot shows up on the scan that wasn't clinically significant. And also, if a spot does or doesn't go away seems very important. So I might be designated as having a poor response to disease because the MFBG is just so sensitive, whereas an MIBG might have told me that I had a good response to disease, and a whole series of decisions might be made based on a scan and based on spots that we don't know if they're significant or not. So it's amazing. It's a great tool, but we need to get smarter about it. And as we begin to adopt it, we need to do the right trials to figure out what's significant and what's not significant. So I'm all for it, but I'm also for learning about it. Just in the same way that we did, not we, I wasn't around, but my predecessors, when we got better and better at CT scans and better at MRI scans, there was a learning curve. We had to learn to use the new technology smarter. Liv, did you want to say something?
Yeah, thank you, Ro. I think you already explained it a lot.
Could you introduce who
Okay.
you are, please?
Sorry,
Thank you.
I'm Liv Tietgets. I'm from Utrecht, Princess Maxima Center. I'm a pediatric oncologist, and I will talk about liquid biopsies this afternoon. But we also did a study on MFBG, comparing it back to MIBG. And of course, Ro, everything you say is really correct. But there are a few things we really need to solve. If we want to do this in Europe, not all centers, not all countries have the cyclotron, so can make the MFBG, so then we also have the inequality. So this is something we need to work on. And the second thing is, MIBG is in Cytopen is being used as clinical decision-making cut points. So what are the cut points on the MFBG scan, and how do we use these? So we really need to learn for the clinical implementation if what we see is indeed important and correct, and not overtreat the non-high-risk patients based on the novel scan. So I hope we will make come up with the answers in the coming years, so really to move this forward.
Thank you. Leona has a question. Thank you.
Thanks. Cormac. Is the mic on?
Yep. Yeah.
Thanks, Cormac, and thanks, Ro and Juliet, for the talks. Leona Knox, parent advocate working with SKC. One of the things I think for us as parents, and certainly for me back in 2011, was I want to know what the best way is to treat my child's disease, where you talk to the complexity of trying to understand, diagnose, and what to do. But could you speak to you talked that the US and Europe are broadly similar in the approach, but there are some differences, and I think that can be really confusing for all of us, and other parents, and the parents on the stage can speak to that. Why are there differences? Why are we at this point? Is there any effort to approach the disease in the same way, or what are your thoughts?
I think that was for you, Ro.
Okay. So there's history in all of this, and what we have done on both sides of the ocean is take something that works and then add, and then add, and then add, and then add, and we never take away, because the survival rates are not acceptable. And so we don't feel ever like we can back off, because we still have such a long way to go. So a reduction in therapy question in neuroblastoma has not been acceptable up to this time. But the question, as we understand more about the biology, is why do we have to use all the components of therapy for everybody? So if I had neuroblastoma and my tumor was exquisitely sensitive to immunotherapy, why would you need to put me through high-dose chemo with stem cell rescue? But right now, we don't have a way to know if my neuroblastoma, as opposed to your neuroblastoma, is exquisitely sensitive to immunotherapy. And that is the problem. We have all these treatments, but we're still learning which kind of tumor is sensitive to what. So if Juliet's tumor were exquisitely sensitive to radiation, for example, one could argue that maybe she could get a little bit of induction therapy, but radiation of different kinds, either standard external beam radiation or MIBG therapy, might be uniquely important for Juliet's tumor as opposed to my tumor, that really the emphasis should be on the immunotherapy. And that's where we want to go, is to understand the biology of the disease so well that we could sit down with each family in the room and say, I've carefully analyzed this tumor. this is what the biology is telling me, and here's your treatment regimen, and then walk into the next room of the next patient and say, completely different, this is what you need. And we're not there yet. The problem with the data is that it takes patients as a group and not as individuals. And we know that patients, children, people are all individuals. But we can only do the best that we can, and so we have to still study groups because we just don't have the tools and the power to work on that individual level. And so studies are done in groups of patients that might be tilted with one flavor of patient, if you will, versus another, and they get different answers. I think that's a little bit what Juliet was talking about with the issue of single-arm studies. The group of patients, the mix of patients, if you will, is a little bit different in each study, and so you may get a different answer. But times also change. So patients are very individual, but times also change. And so in the 1990s, when the studies showed that high-dose chemotherapy with stem cell rescue really made a big difference in the outcome of children with neuroblastoma in that era, that's what we had. And the thinking in the 1990s was, if a little bit's good, more must be better. And it turned out that that was true in the studies in Europe and in North America. But we're not in the 90s anymore. And so is it possible that a different approach, like in the immunotherapy era, do we still need high-dose chemo with stem cell rescue in the way that we did in the 1990s? I don't know the answer to that. And I think it needs to be studied in a randomized trial so we could finally, for once, answer that. And you know this very well because it was you and some others as parents who really advocated for, you guys are confusing us, doctors. You're making this harder, and we need a really solid answer. It's time for you to answer this. And our colleagues, the parents in the room and particularly in this corner, published a paper in a medical journal that I think really spurred us to get it together and propose a trial and design a trial to answer this question so we don't have to, all of you don't have to struggle with, well, this group says this and that group says that. We need to study them head to head and give you the answer that you need. I hope that addresses your question.
Thank you. We have another question in the middle.
Hi, I'm Helen, mum to Michael, who's about 2 years post-treatment now. My question's for Naomi and Mandy. No offence, professionals. I was just wondering if you could speak very briefly about what decision you made, regarding further treatments when your child had finished their frontline treatment, how you made that decision, what were the kind of most important factors? Because I know we have families here today who are approaching that decision or in the middle of it, and what was most useful to you?
Shall I go first? So my son actually is a case that doesn't fit the algorithm, as it were. He sort of very briefly, he was diagnosed in 2019, aged 8.5, with a single localized tumour in his chest. He didn't particularly respond to rapid Kojak, but responded enough that the surgeons were able to remove the tumour in its entirety. He then had radiotherapy and retinoic acid. Finished treatment in February 2020 and then relapsed in August 2020 with a skull tumour and bone marrow disease. So he'd moved into the high-risk category. He went through chemo and then chemoimmunotherapy on the Beacon trial and then radiotherapy on his skull tumour, and then the UK ran out of options for him. The skull tumour had been stable since December 2020, and so this was July 21. July 21. We were trying to make decisions about what next, and we looked at the naxitamab trial in Leeds, and he wasn't eligible for it because he didn't tick the criteria boxes. But we didn't feel confident about leaving everything at that point because his skull tumour was still showing up on MIBG. So we kind of had this period of watch and wait for about 6 months while we got second opinions and talked to various people. We spoke to Dr. Mora in Barcelona about naxitamab in Barcelona, and we talked to Dr. Scholler about DFMO. And in the end, the decision came down to DFMO was easy, as in it was an oral medicine, low side effects. We felt we could raise the money to get over there to get it, whereas naxitamab potentially involved moving to Barcelona because of potential complications while he was having the treatment. But there was no data for my son. There was no data for his very specific circumstances. So in the end, it came down to, are we happy to continue watching and waiting, which is what the UK could offer us, or do we want to do this therapy that doesn't seem to be causing any harm and could do some good? And that was how we made the decision in the end, was we didn't feel comfortable doing nothing. About 18 months into the DFMO trial, we finally persuaded our UK consultant to do a PET scan so that we could figure out what was going on with this skull tumour that kept showing up on MIBG, and that came back negative. So we don't know when it became negative, because we could have done with having that information right at the beginning. But he is now no evidence of active disease. He finished DFMO a year ago in January, and so far so good. And yeah, that's kind of how we got to where we are now. Just the case of, well, we don't want to do nothing, but we don't want to do something that could be extra harmful. And DFMO just seemed like a easier option than anything, and it certainly was. For the 2 years that he was on it, it was almost like normal life had resumed, and it was minimal side effects. He did get hearing loss, and it didn't come back afterwards. So he's one of the, again, he seems to tick all these unique boxes along the way, but he's one of the very few children who had hearing loss and it didn't return, but it's not affected him either. It's not held him back at all. He's in his first year of GCSEs and absolutely smashing it, and you know, he's doing really, really well. So it was the right decision for us at the time. But what I would say about decision making is it is incredibly difficult when you're doing it, and you have to just make that decision based on the information that you have in front of you at the time and how you feel about it. And quite often you're making that decision with very little data. So you have to decide, I've made this decision, and then move on from that, and don't look back on it, because it's too difficult to sort of decide how you would make that decision if you then have information later on down the line. Like if we'd known that he was PET negative at the beginning, would we have done DFMO? And I don't know what the answer to that is, and I don't think it matters. So that's our experience.
Our experience is a bit different. So my daughter Phoebe was diagnosed originally with MS, and then relapsed or progressed and moved on to high risk, although she was never McKen amplified. She relapsed and became refractory, so she relapsed 3 times, but did have an ALK mutation, so went on to a ALK inhibitor prior to lorlatinib. And after 12 months of that, we were in a position where we felt we could move on to immunotherapy, which had become available by then. And she got her first clear MIBG after 2 cycles of immunotherapy. So when we got to the end of standard treatment, although it hadn't been standard treatment, she hadn't had radiotherapy. That was the only thing she didn't have. At that time, there was less data from DFMO, so we had kind of discounted it already because we weren't confident that we wanted to do that. We had a lot of reservations about raising money to go abroad, didn't feel comfortable being very, very public. And we looked at vaccine as well, but actually she was not eligible at that time. The criteria to go on to vaccine, she didn't fit. So there were those factors, but mainly for us, we'd been in treatment for nearly 4 years. We felt fortunate in a way that she'd had the ALK inhibitor and that had cleared it. She had an older sister, and we just really felt like we didn't want to do any more at that point, and we knew there was a chance that maybe she might relapse and we might think back and think maybe we should have. But at that time, for us as a family, we just decided that was the right thing for us to do. And I think, like Mandy says, you just have to take where you are and your situation, and no one knows your personal situation like you do. And yeah, you just have to make a decision that's right for you at the time. And for us, we didn't, and we're 5 years on, and touch everything wooden, and we're okay. You know, she does have, you know, side effects and late effects, hearing loss, cognitive issues, but we are very, very grateful that we are where we are. Yeah.
Thank you very much. I think we have an online question or theme.
Thanks so much. Yeah, we have a couple of questions. Some were answered already in the discussion, but there's one, Ro, you touched upon radiotherapy. And one of the questions is, are there considerations for not doing radiotherapy at all in high-risk tumors? And what is the view toward the future and as far as future protocols?
I'm happy to answer, but I also want to include you.
Oh, thank you. Thanks for it. Much appreciated. I think radiotherapy is a difficult and probably. I can talk a little bit about radiotherapy because it comes with side effects, but actually there are other experts in the room who know far more about radiotherapy than me. But I wanted to mainly add that going back to some of the decision-making questions, it's really great to hear from the parents' perspective what goes into that decision-making process. And I know that with some of the people in this room, actually, we've made these decisions, really difficult decisions. And I think there's a lot of I feel like we're constantly hand in hand walking that tightrope of toxicity versus benefits, and you feel like you can tip over into either side so easily. And I think radiotherapy fits into that category, doesn't it? And it depends so much on which area, at what dose, whether you're going to give a boost, whether there are other things. And it goes back to your point about in the era of immunotherapy, other drugs, DFMO, which of those bits can we remove? And I think, can we learn from adult practice? Can we learn from other pediatric tumours in terms of removing some of those aspects of toxicity? But I think circling back to right at the beginning, perhaps we're not quite there yet with neuroblastoma because our goal is still to improve outcomes, but we mustn't forget the toxicity in the middle, because I know there are many people in this room who have had significant toxicity for and still live with the long-term effects of that toxicity that we give you. So I think I'm just raising questions rather than answers, but I guess the summary of all of that is there is no easy decision on where to go, and it comes back to the individual child. But to me, more radiotherapy is a difficult one. But an easier question perhaps to answer is the high dose, because that carries such significant toxicity. Should we address all the components that have been shown on the screen step by step, going from the highest toxicity treatment, trying to remove aspects of that and then work our way down. And I think learning from the leukemia group is a really nice example, because the pediatric leukemia group have worked similar to us, have been of this mindset of can't remove areas of treatment because will impact final outcome. But they've finally entered a brave new world of removing de-escalating therapy. When will we ever get there? I don't know. Perhaps people more experienced than me can address that.
I'll circle back, Donna, a little bit to the radiation piece, just because I don't want to. I think what you've said is really important, but I also want to address that person's question. For the pediatric oncologists in the room, I think we think of the radiation dose as relatively low compared to other cancers. It's not a free ride. There's toxicity associated with radiation for sure, but relatively speaking, the dose is pretty low, and by and large, the toxicity is manageable, and the rate of local relapse, like recurrence in the primary site, is pretty low compared to the rate of metastatic relapse. So we think that the combination of safe but aggressive surgery plus radiation is pretty effective. And my fear about backing off on radiation too much is that we would see the rate of primary tumor recurrence increase. And I just think that would be a pity. It's pretty low right now, and we'd like to keep it there. That being said, we're taking small steps to try to reduce the radiation dose when we can in the children's oncology group. So our current study has a relatively conservative step towards reducing the dose in certain patients. The question that we have in the children's oncology group is about radiation to metastatic sites of disease, which has been the practice on our side of the ocean for quite some time and has not been in the practice in Europe and the UK. And our survival rates are pretty similar. So I think we do have a lot to learn about radiation, but I would hate to jump away from radiation to the primary tumor site since it seems to work. I guess we should ask, I mean, do you have any comments, Mark? No.
Okay, but so unfortunately we're going to have to stop because we're on pretty strict timelines. They're nodding heads at the back. I would like to sincerely thank the speakers and our panelists. I'm sorry we didn't have more time to talk, but we do have a bit of time at the coffee break, so I want to thank you all very much. There will be a break. We're starting at 11 a.m. GMT sharp for the next session on treating relapse and refractory disease. There will be a countdown as before, so a little bit less time for the planned coffee break. Thank you.